that there are no roadblocks in this road map, which is H202. Any measure that you put into H202 that might increase bureaucracy or inefficiency should be carefully considered, since obviously one of the goals, or the end goal of single payer, is to reduce cost through greater efficiency and less paperwork. Now, I know that's a little hard for you because there are parts of H202 that are necessary. They're a transitional phase that's required by federal law. You know, because of federal funding, you may not get an early waiver, you have to construct exchanges no matter what for federal funding. I also understand that medical homes and the paid for performance projects and, you know, may qualify for federal funding, which you all want. So already, by saying you shouldn't put any roadblocks into this roadmap, I understand that that's difficult. However, I would suggest a slight change in pace on the payment reform projects, and I know there's a lot of pressure coming on you about those. But I'd like to have you refer, first of all, to the guidelines that Professor Xiao has outlined about these in his final report, in his first report. First of all, as Professor Xiao reminds us, there is very little evidence about how payment reform projects would actually work in Vermont. And in Xiao's draft, these are called ACOs, but this is a parallel concept because ACOs are the entities that would be the focus of payment reform. And clearly they are, you know, entities that would be constructed to coordinate patient care and would be on the receiving ends of different kinds of payment. And I think this is also clear in Richard Schlesky's, you know, preliminary report. He only uses the word ACO a few times, but it's quite clear that he's talking about elements in organization that parallel ACOs. And so my comments are meant to say, you know, you might want to go slow about these. First of all, you want to consider that ACOs have never exactly been implemented. They are a concept. They were developed by Elliot Fisher at Dartmouth. And, you know, it would be very interesting if we had a lot of time to look at how that concept was developed and how people glommed onto it and why it became popular and it finally got implemented into PPACA. But I would suggest that where a single payer is not just a concept, it's something we can look at in many different places around the world and see how it operates. We can look at Medicare. That's a single payer for people over 65, and it has problems, but, you know, it's got a lot of good sides, like 3% overhead. Unlike single payer, ACOs are merely a concept. You know, we can barely see them anywhere. So, for instance, on page 161 of Xiao's final draft, you'll see him talking about, well, what would an ACO be in Vermont? And he says it could be a federally qualified health center, it could be a community hospital, it could be Fletcher Allen. And, you know, those are very divergent entities. So, to move us to H202, I found something else here, that you've defined everything else in the bill. For instance, you define healthcare professionals. Even though that seems like an obvious concept, you say healthcare professional means. You define Green Mountain Care. You define board. But there's no definition of payment reform or a payment reform pilot. And that's a problem in a bill. If you're going to implement something that you don't even say, this is what it means, right? This is what it means. So that's the first thing. Secondly, there are many complexities to this enterprise that certainly worry me as an advocate of single payer. Again, single payer is easy to understand. Payment reform is complex and sort of never been implemented. Just to give you a couple of ideas, and I won't take up too much of your time, but for instance, in an ACO and in your bill, not your bill, in H202, you know, we're assured that patients would have free choice of doctors and hospitals, and they wouldn't be restricted. But you're going to measure savings. How do you measure savings if you don't have members of the entity you're measuring savings for, right? That's problematical. How do you attribute savings to a patient who is not defined as a member of your group? How do you pay per member per month? You know, the idea of a capitated payment. Well, you know, we'll pay per member per month for your entity, right? Each of you will get a payment, or, you know, the entity that's whatever it's called, ACO or whatever, will get a payment per month for you, and you. but yet you're not a member of it, right? If you were a member and you were forced to be a member, that would be an HMO, and we know that would be a disaster, and there would be a huge, citizen revolt against that, and we've tried that, been there, done that, and that's not good. So you don't want to do that. And also, to figure this all out, well, you need a new bureaucracy to oversee this. So what does this say? Maybe you need to get the new financing system in place, single payer. I know that will take some years before you get too far into this payment reform enterprise. I would also suggest that in the bill, H202, they talk about, well, the insurance companies will help us in this payment reform process. But then the insurance companies are not going to be there after a couple of years. So they're in on the process of payment reform, and then they're out of it. And that seems to me very complicated. So in short, I'll just wrap up and give you a couple of suggestions. To be successful, payment reform needs to be part of system reform, but it shouldn't precede system reform. And the real system reform is single payer. And what I find difficult here is, getting all this payment reform started in this transitional phase, and then you're going to have single payer, and how does that mesh? It seems like a lot of complexity, and I worry about public reaction. If you get a bunch of complex things started in one phase that's merely transitional, then you're going to single payer. How does that work out? It is unlikely to succeed if you implement payment reform outside the context of systematic reform. We certainly don't want it to turn into an HMO, and if you haven't even defined something in the bill, you haven't even said payment reform means, like you said, board means, and healthcare provider means, even though we all think we know what they mean, you really have to be careful there, and you can't implement something, on a wing and a prayer. So here are my quick suggestions. Obviously, I think you should pass the bill. It's a roadmap to single payer. I will also say, and I know every other single payer advocate has told you this, and I second and third them, you should make clear that single payer is the point of the bill. Put that up front. The point of the bill is single payer. It's the goal of the bill. The exchanges, these are intermediary stages. And single payer should not be constructed in the bill in such a way that it's kind of an afterthought and it could be aborted, right? So here are the specific changes I would suggest. First of all, on page 17, I think that you need, where you talk about payment reform pilots, and right now you have one pilot that will be operational no later than January 1st, 2012. Hello, it's already like March 2011, that seems awfully fast, and 2 more pilots to be online by July 1st, 2012. I would suggest, why not 1 pilot to be completed by a year from this, 1 pilot, and then, and this is very important, Professor Xiao says on page 159, all payment reform pilots must undergo rigorous evaluation. Those are his terms, rigorous evaluation. You cannot undertake anything on a large scale, and I know there are all these people who come in here who've got all their projects, underway, but you really want to write into the bill this language about rigorous evaluation. I haven't found that Xiao's language of rigorous evaluation of these payment reform pilots is actually in the bill. That should be there. It shouldn't just be, well, they tell us they're going to rigorously evaluate. I think that should be part of the bill. Thirdly, you need to define payment reform, just the way you define healthcare providers, boards, Green Mountain Care. This is a major concept. I'd like to see you go slow on it. I'd like to see you scale down from 3 to 1 before July 1st, 2012. But you certainly need to define it, or you've got a real problem there. So I'll summarize. We don't want to add something that might possibly add more complexity to the simple and very efficient system that is single payer. Single payer is not a concept only. It's not just some academic's idea. It's an actually existing system that is existent in many places. Now, payment reform and ACOs are much more tricky because they exist primarily in the concept world and not in the real world. So I would suggest a go-slow approach, and in specifically those, very discrete changes that you can make on page 17, Part E, as you discuss payment reform. You must define it. I would suggest a slow approach, and I would definitely suggest adding language that comes from Professor Xiao's final draft, page 159, on rigorous evaluation. So those are suggestions. Thank you very much. Any questions? Yes.
I'd like to have copies of your testimony.
Yes, what I will do is I will email them to Lauren, and then, is that okay? And then Lauren can give that to each of you?
And also, you said that to count individuals in the ACO, you'd have to be a member, and that would mean an HMO. We don't want that. What do you mean by that?
Okay, let me explain that, right? So, part of the idea of an ACO is that you change the way you are going to pay the providers, right? You do what's called a capitated payment combined with a little bit of a pay for performance, which means that, let's say I'm one of my 20-year-old Middlebury College students who get paid less for them than me, than an 84-year-old, they figure that out, they call it risk-adjusted capitation, right? So this entity, the ACO, gets paid a certain amount for each patient. And the idea, and you can see that in Richard Slusky's report, and others, is we'll get away from fee-for-service, right? And therefore, the idea here is, there's a bunch of doctors sitting there thinking, how many tests can I make up for you so I can make money? I'm not saying I believe that, but that's the idea. So this idea is we can save money by paying per patient. Then we can measure all the great savings we're going to make by a measurement of how much we saved, per month, per patient, by doing it this way. The trouble is, it also says in Professor Xiao's report, and it's also actually in the concept of ACOs, as defined in the literature and in the bill, you can't force somebody to be a member, right? So membership in the ACO is going to be by just saying, are you visiting this place? Then you're a member. But, and in fact, Xiao, I think it's between page 158 and 162 of his final draft, he talks about this problem. He says, how are we going to do this? We can't force people to stay in the ACO because you have free choice of doctor. None of you here would want to feel like you were forced, right, to stay with, one provider or one entity. Yet how can we count a savings from a person who is not a member? Does that make sense?
Yeah, but my question was,
Yeah.
that was good, thanks. But my question is more, so I'm trying to get at why we wouldn't want to be able to count members. Is it the problem, do you have any problem with the setup of an ACO?
Yes, because you can't count members because you don't really have members. You don't have members because unlike an HMO, and you remember the old HMO, you had to stay in this HMO, right? You couldn't seek care elsewhere. As Professor Xiao says, and the bill also says, but Professor Xiao says, and all the literature on ACOs, and it's one of the reasons that's a dicey concept, right? It's a concept, it's not something down there on the ground that we've seen, is you can't assign people and make them stay. You could do that, but it would be, I wouldn't suggest it, it would be politically very unpopular. I think you would have a huge backlash. And in fact, it could undermine the whole healthcare reform process, because if people feel like they're stuck, right? Like you must go here and you can't change. So, but ACOs honestly don't figure that in their definition. But since they don't, it's sort of dicey how the payments are supposed to be per member, yet there are no members. So that's very dicey. And what I would suggest is, I'm not saying, throw the whole thing out, but I would think you could easily, within this bill, construct the language so that you slow down the payment reform pilots, you put in language about rigorous evaluation. Let's see how this really works. Let's make sure it's rigorously evaluated. I think there are certainly some very contradictory and problematical elements to this whole idea. It's, was glommed onto by various national figures, and quite frankly, who knows if it was just seen as another way of circumventing single payer, right? Because if you look at the people who really love the idea of ACOs, a lot of them are people who were trying to find some fancy way around single payer. And yet, do you want to add something and commit to something that's going to be more bureaucratic? When I look at what you have to figure out with an ACO, you'll need a new bureaucracy to oversee those. So it would seem a shame to me to unconsciously, that's why I would call it a roadblock in a roadmap, right? You're unconsciously undermining the simplicity and efficiency you're trying to get to with something that's much more complex. And you know, I don't spend a lot of time up here, but when I'm up here, I hear people, and you know, I do check up on testimony, and I know there's a lot coming at you to go forward much faster with these. But there's also a real problematic tie-in, because how do you get something started in the transitional phase with insurance companies? You have one, you know, kind of one organization, and then you have to redo it with single payer. So why not just say, you know, one payment reform pilot, you know, we'll rigorously evaluate, put that all there, define them. You certainly want to define them. I found that interesting because, you know, every bill at the beginning says such and such means, and this means, that means. It said, there's nothing that says payment reform means. So, that's interesting.
So I think we have another question, Paul.
Yeah, I just want to say it's really nice to meet you. I've read a lot of your newspapers and your articles on single payer, and so it's nice to see a face
nice
and a
to
name.
meet you too.
I just want to say, you said something that I have totally believed in, and I still haven't figured out how we avoid it in the future. This whole thing of ACOs, I mean, when you said it's all conceptually and everything else, and I've always believed that it was really pushed by people who didn't want single payer.
Good thought.
And what we had, and this is a concern I have as we move forward, the way this time schedule for this process, for this bill is, I mean, we have to go through maybe 3 elections to ultimately get this thing to where it's going to go. And we just came through, you know, a period where, in no disrespect to any of the people, but their personal philosophies, we had a governor who was not supportive of single payer. We had leadership on this committee who was not committed to moving to single payer and was moving more interested in the long-term development of ACOs and the blueprint and everything else. I called that generational change. In 20 years, we would have started seeing. And so when you say the word, and it may be picky, but because people pick up on just little words and they use it, as I do, to my advantage when it favors me.
Yeah.
But you know, when you said go slow, you're not in any way insinuating we should go slow in implementing. And if we had our perfect world, we would even eliminate the exchange and go directly to single payer.
Right.
Okay.
In the perfect world, we would get rid of the whole middle section of the bill, which I said we can't do because of federal law and because of the funding coming. And I'm not, I'm not one of the, you know, right-wing people that's come in and say, go slow because we don't want single payer. What I'm saying go slow on is just this piece of it, the payment reform pilots, and make sure that I would go from 3 to 1 by July 1st, 2012, because after all, this is March 2011, and I would absolutely write in the language about rigorous evaluation. You can quote that from Xiao. You know, I like to use Xiao as kind of, you know, kind of roadmap too, because he's got a lot of really good stuff in there. And he's back and forth on ACOs, and I think the reason his report is like that is he was handed that because it's part of PPACA. And why was it part of PPACA? Well, that's a whole, you know, it probably got developed by, it was developed by Elliot Fisher, it was picked up by forces that he, you know, who found it a very, very convenient concept. And Professor Xiao had to deal with that. But he's also very clear, you know, he says, we don't know what they would look like. We have no model. They must be rigorously evaluated. So what you should go slow on is something like that. And yeah, we all worry about 2017 and, you know, what happens. We don't want another legislature. We don't want another, you know, we need, right? It could be another legislature, another governor. We hope not. But certainly the worst case scenario would be you would get all of these things in the middle and never end up with your end goal, which is another reason, separate from my commentary on payment reform, you want single payer to be written right up front in the bill as this is the perfect, the purpose. It can't be sort of aborted, we got to part 2 now, drop off part 3, in 3 years or so.
Alan, we have one more quick question.
Yeah, and I know you're running behind, so.
So,
yeah.
Chris.
Yeah, I appreciate your testimony, Alan. I'm curious, I like what you had to say about membership. I think that we've talked a lot about one of the elegance of having Green Mountain Care is that it's sort of like a library. You don't have to have a card in your pocket, but I think it was the chair's analogy, you walk in and you are a member. And I like that piece, and I wonder if you think it might work to base payment systems on just data. And down the hall, as we're starting to do redistricting, we have enormously sophisticated analysis of who lives where in our state and in fact in square blocks. So do you think that would be a basis to maybe measure it, or do you have any opinion on it?
Yeah, I mean, there are plenty of studies of different kinds of payment, and by the way, one that has not been mentioned is salaries. 65% of the primary care physicians are on salary now in Vermont, and that seems a whole lot easier to understand than capitated payments for members who aren't really members of an entity that doesn't really exist. So I would think, and there are lots of people much better than me that on that. Obviously, there are tons of sources of the studies that have been done. And so, yeah, I would suggest looking at it. Great. Well, thank you so much.